We are now into chapter 44, the third chapter in the cardiac or cardiovascular section. This one is on antihypertensives. I'm not going to go a lot into the whole function. You would have had that in your pathophysiology, also in some part of your med surg. I don't know if it was some fundamentals or whether you're getting into more now. But understanding the RAAS, the renin-angiotensin-aldosterone system, a little bit, not that you need to memorize this system, but having an idea is when we start talking about some of these drugs. Some we've already talked about, like beta blockers and calcium channel blockers, and we'll bring those up again. But in here, when we start talking about ACE inhibitors, the ARBs, angiotensin renin inhibitors. So it's different places in here, and I'll bring it up some more to show which places those medications affect and how that ends up decreasing blood pressure, and ones that we vasodilate down here. So this is just to kind of help you, and this note: water and sodium retention, increased circulating volume, increased renal perfusion. So that's just an FYI. The beginning of your chapter goes over it. Your chapter also talks about culture response, non-pharmacological control. That is, if you want to look over that, but that's not what my focus on is in the pharmacology class. So diuretics were in your last chapter. Again, diuretics can be used for control of blood pressure just because of pulling out sodium in different places and pulling off excess fluid. So I threw this in there just to, again, remind you of the different parts of the tubules that things take place. And a big one, the thiazides that work over in here with the sodium excretion. They are often used with hypertensive management. It is the JNC7, which are the guidelines for blood pressure management. The JNC7 guidelines do say the very first line of drugs is the thiazide. So you're supposed to try them on a thiazide and then start adding in some other drugs. I just threw this in. I thought a little humor along the way. I'll try to use a little more of that. I'm going to take your blood pressure, so try to relax and do not think about what a high reading might mean for your chances of living a long, healthy life. I just thought that was cute. This is a general chart. I know the chapter might seem overwhelming. I'm going to try to break it down and tell you where to focus. Some of these, although they're broken down in others, I'll get there. I'll help you through this. As you can see, adrenergic, we're back to that parasympathetic and sympathetic. We're on the sympathetic side of the nervous system, or the fight or flight, with your alpha 1, alpha 2, beta 1, beta 2 receptor sites. So if you need to, go back and look at those, but we will be discussing them. We'll be staying over here because we're not going to stimulate the sympathomimetic. If you remember, the sympathetic nervous system, it mimics it. We don't want to mimic it. We want to block it, stop it, suppress it. So we are more on the sympatholytic, lytic like lysing or going against, or as it says here, adrenergic depressants. And then it breaks them up into this, or breaking this further. Another chart. I'm giving you all these charts to try to help you as we go along. Some of these charts they're in your PowerPoint that you can print off and may want to take notes on as you're reading, or helping you remember. I thought this one, ignore up here. We are not dealing with this. This is when you're getting into vasopressors and other. We're not going up there. I want you just to stay down here. And the majority of the time you're actually going to be in this vicinity. So we will break these down, talk about them some more. I just thought that this was a really good chart to help you reference. Now we're going to start on your beta blockers, which we already covered again, like diuretics, and then we have the sympatholytic, like I mentioned, or sympathetic depressant. 5 groups. The first of those groups are the beta blockers. Now, we talked about the beta blockers with slowing down the heart rate, and it blocks the adrenaline on that right side, that fight or flight. It blocks it. Remember, you have beta 1 and beta 2. So when it talks about beta adrenergic or beta blockers, because they're commonly just called beta blockers. Beta adrenergic is just on that adrenergic or sympathetic side, the beta cells. They dilate the artery. By dilating, it has more room, so the blood pressure comes down. Slows the heart rate, so the ventricle can fill better, so the heart is not working as hard. Side effects, and again it says adrenergic antagonists, agonergic blockers, or this B is your beta blockers. So they're blocking, some block the beta 1 and the beta 2, some are selective for one over the other. Now, if you remember the picture of your heart, of your sympathetic, you have one heart, 2 lungs. Your beta 1 is for your heart. So if you have a selective, it's going to hopefully be selective to just beta 1. So it's not going to have the effects on the lungs of the beta 2. If you have an asthmatic or COPD, you certainly don't want beta 2, because the beta 2 is going to constrict the lungs. On table 44.1, it gives a list. We're going to stick to the top initially. Beta adrenergic blockers, or your beta blockers. And as you can see, thankfully on every single beta blocker, the generic names end in OL. OL, OL. So if you see OL, OL, it is a beta blocker. And these are the typical things with a beta blocker. It decreases your blood pressure, so there's a risk of hypotension. Because it's dilating and relaxing, slowing your heart rate, giving it more fill time, you can have a chance of having congestive heart failure. And it does slow down the heart rate, so there's a chance of a conduction problem in an AV block. Because it slows everything down, you can have drowsiness and depression. With non-selective, meaning it's working on the beta 1 and beta 2, you also can have a problem with hypoglycemia, because remember the beta cells have to do with your glycogenesis, the breakdown in the glucose. So sometimes if you have a diabetic and they're on a beta blocker, non-selective, which I believe all of these are non-selective, you have an increased chance of masked signs of hypoglycemia. Now, if you notice here with the drowsiness, depression, what actually sometimes low doses of beta blockers can be used to help someone with anxiety, like stress anxiety, taking a low dose before an exam to help bring that anxiety level down. So metoprolol is cardioselective. Okay, so in your text you have the pharmacodynamics on this one, metoprolol, which is cardioselective, means it's selective for the beta 1, so it won't affect your lungs. It'll decrease the heart rate, decrease the blood pressure without affecting glucose and without affecting your lungs, causing constriction. Beta blockers do cross the placental barrier and are excreted in the breast milk. On your chart 44.1 on your metoprolol, notice children, it's greater than age 6. It's contraindicated in, or caution if used with people with type 1 diabetes, not type 2, but type 1. And acute heart failure, it's not to give it if they have acute heart failure, because of course here it can worsen the heart failure. Onset is immediate. Although it says adverse effects with hypoglycemia not as likely with the cardioselective. It should never be abruptly discontinued. Any beta blocker or any beta blocker, because you could have a rebound hypertension. The non-cardioselective beta blockers inhibit the liver's ability to convert glycogen to glucose in response to hypoglycemia. That's the thing with the non-cardio. I was trying to remember. In addition, the depression and heart may mask the symptoms of tachycardia and hypotension. So on your beta blockers, as far as frequency of seeing these drugs, these are the ones you will see the most often: propranolol, atenolol, metoprolol. And of these, your atenolol and propranolol are non-selective, so you would not give them in a COPD or an asthmatic, but metoprolol is cardioselective, and if they needed to be on a beta blocker, that would be safer for that person. On your teaching, let's see, on your patient teaching section, herbal alert, which we'll go over that in a minute. Avoid over-the-counter drugs without first checking with a healthcare provider. That's anyone with high blood pressure on any kind of antihypertensive. Nursing process, check labs related to renal and liver function periodically, so you're talking AST, ALT, BUN, creatinine. So your herbal alert, there is lots of problems with counteracting the drug, causing hypotensive, antagonizing, going against it, which is licorice. So please look over your herbal alert. Ephedra you don't see as much around as you used to. Black cohosh is often used especially by females for postmenopausal symptoms. Licorice, there's a thing where people are taking licorice supplements now too, so it antagonizes the effect of the antihypertensives, and it's pretty broad with all antihypertensives too. So, central acting alpha-2 antagonist. This is your clonidine. Clonidine is the drug you will see in this group. Methyldopa is another, which brand name Aldimet. Methyldopa is the drug that you will see used in pregnancy for hypertension, because it passed the first, really the second trimester, but often we start it in the first. Like methyldopa is the safest one. So clonidine is often given in a transdermal patch. It's like the only one other than nitroglycerin that's actually in a patch form, and it stays on for 7 days. So it's to be left alone. They can shower, they can bathe with it on, leave the patch alone, and change it in 7 days, and to move it to a different site. Clonidine is better when it's giving over a long period of time, because when you smaller doses of it, that you could have a major rebound with clonidine and stopping it abruptly. Side effects: it's affecting your alpha-2, so it's blocking it, and should never be given with somebody with liver impairment. Never stopped abruptly, which I mentioned, because they can go into very severe hypertensive symptoms. It's here where it says contemplating pregnancy, avoid clonidine. It's frequently used for chronic or pregnancy-induced hypertension. It is the drug to use in pregnancy-induced hypertension. And you can see a little bit of how it works, affecting just those alpha-2 receptors. Decreases the systemic resistance, so when the heart pumps, it pumps against less resistance. That's because it's dilating those vessels that it's pumping against. Decreases venous return. Okay. I am trying just to focus on the key points of what you need to know in these drugs. Now, adrenergic agonist. I liked this slide because it's kind of confusing. Look at table 44.2, all these adrenergic agonists. So I just listed here because you have your beta agonist, which we just covered. Now we're getting into the alpha agonist. We just covered the central acting, and then we have these others, the non-selective alpha 1, alpha 2. You can see where they work. Enhanced release of norepinephrine from the vessels, missed action both directly, indirectly. Okay, so your alpha adrenergic blockers, if they are non-selective, they are going to block alpha 1 and alpha 2 receptors. Several of them. Here's like the non-selective ones, and then you have your alpha 1 selective is prazosin, terazosin, and you may recognize that zosin from when we've talked about things back to your autonomic nervous system. Your alpha 1 receptors cause blood vessel constriction, increase your blood pressure, increase contractility of the heart. So if it's a blocker, it's going to dilate the vessels, lower the blood pressure, and decrease contractility of the heart. Your eyes, it causes them to dilate because of fight or flight, but this will cause them to constrict. You have bladder relaxation, so if it is an alpha 1 selective like prazosin and terazosin, it is going to tighten up the bladder. And then the prostate, that's where you'll see these drugs also used for BPH, benign prostatic hypertrophy, because the alpha 1 receptors contract the prostate, and if it's already enlarged, these drugs will be used to relax the prostate so that they can pee. Then when you get to alpha 2 selective, your alpha 2 receptors, they decrease blood pressure. So this would actually pull the blood pressure up some, but okay, yeah. So let me keep moving here. So in general, they work by vasodilating, which lowers the blood pressure. This makes the renal flow stays good because it's dilated. Used treating hypertension in patients with lipid abnormalities because it can help lower the very low density lipoproteins, and lipoproteins we'll be talking about a few chapters from now. The selective alpha adrenergic, I mentioned the prazosin, terazosin, doxazosin, mainly to reduce blood pressure, and can be used to treat benign prostatic hypertrophy, which I mentioned. Prazosin is a commonly prescribed drug. If taken with alcohol, the hypotensive state can be intensified, so that would be in your teaching to avoid alcohol. Like the centrally acting alpha antagonist, which is your clonidine, it can cause sodium and your aldemate, your methyl dopa. Those two can cause sodium water retention with edema, and diuretics are often given in conjunction with these. Some of these that are listed down, this phenothiazines are used for hypertensive crisis. I'm not dwelling on those, just being familiar with this prazosin, terazosin. Note in your pharmacokinetics that your prazosin, large portion is lost during hepatic first pass metabolism. Half-life is very short, so the drug has to be given twice a day, and it is very high protein bound, so you have to be careful with any other protein bound drug, because then, such as your, it dilates arteries, which I said. With prazosin, the heart rate is only slightly increased. Non-selective alpha blockers are more effective for acute hypertension. In your teaching, include orthostatic hypotension so that they want to change positions slowly, go from sitting to standing a little at a time. They can have dizziness, faintness, lightheadedness, especially with their first dose. Nasal congestion because of the vasodilation. So if you think of everything dilating, vasodilation, weight gain, edema, nausea because increasing or decreasing motility in the stomach. Always remember that prazosin and terazosin, a big side effect is drowsiness. Usually you tell people to take it at night. If you think of Zosyn, they're not dozing, they're on prazosin. That's how I remember that one, with the drowsiness, fatigue, dizziness, blurred vision. It is caution, a contraindication for renal disease and angina. Monitor their liver enzymes. My next slide, I didn't realize I had this other slide in here. Side effects of adrenergic agonist, low blood pressure, vertigo. They have the mixed here, your doxazosin, so that's your alpha adrenergic, and these down here that are on the slide are actually your centrally acting alpha-2 agonist. Palpitations, so that's why you're not going to give it to somebody with angina. And the sexual dysfunction because of relaxing too many things down there. On your nursing process, I mentioned the highly protein-bound, contraindicated in renal disease, ineffective sexual pattern, yes, because that's a big problem with these particular drugs. No abrupt discontinuation of any antihypertensive drug. The common side effects are dizziness, lightheadedness, drowsiness. He's not dozing, he's on prazosin. And with any antihypertensive, not to take cold medicine without checking with the provider. And interesting and cultural, Asian patients have twice as sensitive to propranolol on blood pressure. That's interesting. Okay, your next slide here just goes over the different kind of blockers. I thought this was kind of good. I probably should have put it at the end of the slide. It goes into multiple things that you may want to look over. Prazosin short acting and doxazosin long acting. This long acting, but that's for hypertensive crisis. And I mentioned the same symptoms, and the nasal stuff, it is decreased ejaculation impedance, bladder relaxing BPH. I stuck 2 drugs on this slide because these are not used that often. This first one, Reserpine, this is a little picture showing you how it works. It is in your chart, table 44.2, but as it says, it's rarely used. Just be a little familiar that it exists and how it works, that it is an adrenergic blocker, specific NUR blocker, so I put that there. And labetalol can be used alone or with diuretics. It's a twice-a-day medicine, and it can be used IV for hypertensive crisis, and it does alpha and beta receptors. Your next section here, again on your table 44.2, just goes into direct-acting vasodilators. It's adrenergic, the vasodilators. Oh, let me go back here. I think your nursing process, I think I covered. Yes, I did that. Direct-acting arteriolar vasodilators. So dilating the arterioles, starting on page 643. Nitroprusside, that's an IV only during a major hypertensive crisis, only in ICU. The ones to note really are your hydralazine and your minoxidil. They are the two used for monitor severe dose-related hypertension, cause little orthostatic hypertension, but they can have reflex tachycardia, and release of renin can occur secondary to vasodilation, leading to a decreased blood pressure. Beta blockers are frequently prescribed with arterial vasodilators to decrease the heart rate, counteracting that effect. And it says near nitroprusside is acute hypertensive emergency only. And I'm moving through these. I'm just giving you key points to know on these particular drugs. And notice the effects of hydralazine are numerous and include reflex tachycardia, palpitations, anemia, nasal congestion, headache, dizziness, GI bleeding, multiple things. That's why it is not used that often. It's really when you're having a very resistant hypertension. Minoxidil has similar side effects as well as tachycardia, and it can precipitate an angina attack. That's why you don't see them used much. Now we're getting into the ACEs and the ARBs. That's how you will hear them referred to. ACEs and ARBs. So your ACE inhibitors or your angiotensin converting enzyme inhibitors. You'll see it written as ACE inhibitors like this, or ACE capital I, ACE inhibitors. So they inhibit the renin that comes from your kidneys, and angiotensin is converted to angiotensin 1, and it prevents it from converting to angiotensin 2. I always think of angiotensin as the tension in the angio or the vessel. So it prevents it from converting from angiotensin 1 to angiotensin 2. Also blocks the release of aldosterone. If you go back to that initial picture with your kidneys, because the aldosterone promotes sodium retention and potassium excretion. So if you're blocking it, you secrete more sodium instead of retaining it, and you might retain more potassium. So if you think about that, think of one of the things you're going to watch when somebody is on an ACE inhibitor is you're going to watch their potassium level. And you certainly don't want them on an ACE inhibitor if they have a potassium supplement, unless they're on a diuretic and they need it, so you really have to watch them. So this is a good picture. I thought it might help in your memory. World Series of Hearts, today's game will include hypertension, heart failure, and post-MI. So those are the things that ACE inhibitors are often used for. And it gave you some names of them. And if you notice on the ACE inhibitors, the generic names captopril, lisinopril, enalapril, quinapril, they all end in the pril sound. Side effects: postural hypotension, like on most of these, fatigue, renal insufficiency, and cough. Cough is probably the worst problem with ACE inhibitors, is they get this like tickle in their throat. The cough can be very, very annoying, and we'll sometimes have to change into the next one we'll discuss, which is an ARB, if that cough is terrible. Also a risk of having angioedema, which is a reaction with inflammation or swelling in the airway, in your mouth, your throat, your laryngeal areas. So that is another time when you have to stop this drug. Angioedema usually occurs within the first few weeks of using the drug, but I did have a patient that was actually on an African American that was on it for 6 months before she had that reaction, which was odd. It's also not very effective in African Americans. Usually have to go to a different class of drugs. For patients with renal insufficiency, reduction of the drug dose is necessary. Over on table 44.3 on page 644 gives you a whole list, but they all end in pril. Don't have to go down memorizing all these names. They all end in pril. They're all a category D, or basically just think of ACE inhibitors. Don't give them during pregnancy. Easy to remember. Side effects, it talks about that irritated cough. That is their biggest problem. With your nursing process, I'm looking for drug-herbal interactions. which were covered earlier. I would just attribute those herbal interactions with all antihypertensive drugs. Again, your lab values, you're checking your BUN and creatinine for your kidney function. And in here, you want to watch your white blood cells. Also, you're watching the potassium because of it blocking that aldosterone, which might make you retain potassium. Nursing interventions, that postural hypertension. Usually the drug might be an impact first and it gets a little better. I've had people, some are very, very sensitive to ACE inhibitors and get really tired, so they take their medicine at night. Most are fine, but every once in a while there's the some. Warn patient not to abruptly discontinue because of rebound, especially that's on the Captopro. Significant rebound hypertension on Captopro with stopping it. Side effects of dizziness, lightheadedness during the first week, especially Captopro. One patient, the taste of food may be diminished during the first month of drug therapy. Avoid foods that are high in potassium. I put this slide, even though it says Captopril, this one is Fosinapril or Monopril, so they really apply to the ACE inhibitors, so I thought this was really good ways to remember things, because I mentioned all of these. Well, the proteinuria, because remember you're watching your kidney function because of the restrictions, and you don't give it in pregnancy. So I hadn't seen this before, but just the Captopril terminology for all the prils, for all the ACE inhibitors. So the cough, angioedema, proteinuria, taste change, hypotension, pregnancy, rash, increased potassium, renin, low angiotensin II, aldosterone. I thought that was an excellent mnemonic, so I put it in here. We're going to move now to the ARBs. Now these are angiotensin II receptor blockers, or ARBs. And you will hear them called ARBs like it's written there. I thought this was another good tool for helping you remember. We block the action of the angiotensin II. We are a team. Angiotensin II, oh no, we can't get through these ARBs. And notice valsartan, losartan, olmesartan. Again, all the ARBs end in the sartan. So with the generics, easy to remember because they end in sartan. Foul blockers can cause angioedema, fetal harm, and increased kidney damage does not cause hyperkalemia or cough. So just like the ACE inhibitors have the same restrictions except for the hyperkalemia and cough, because it does not block the aldosterone, and they don't have the cough, although they can have the angioedema. Although it says not on the fetal harm, they are category C and then D in later pregnancy, and as I said, it's your levodopa or aldamet that's going to be used in pregnancy. With the exception, there's a note here, with the exception of Lexapro, they should be taken on an empty stomach for maximum effectiveness. So all ACE inhibitors can be administered with food. ACE inhibitors, I was like, I didn't know that. I was reading it wrong. ACE inhibitors can all be taken with food except for Lexapro. So just figure they can be taken with food. Talked about the cough, the potassium, contraindications, pregnancy. Should not be on a potassium-sparing diuretic because of the hyperkalemia. I said not to take it with the potassium-sparing diuretic, so this says the combination of losartan, hydrochlorothiazide, or valsartan and hydrochlorothiazide should not cause serum potassium excess or loss, so because those are not potassium-sparing diuretics. Well, valsartan, one of the sartans or ARBs, rapidly absorbed in the GI tract, undergoes first pass metabolism, high protein bound again, just like your ACE inhibitors. Half-life 6 to 9 hours, so they'd have to take it a couple times a day. Oh no, 18 hours, so once a day. Sorry about that. Here's another slide that I found that I thought would be good on INO daily weight side effects. Not so much the potassium level as you would with the ACE inhibitors. I disagree with that. Reinforced patient education. I think it's contraindicated in pregnancy, although part of your text does not say that. It would be contraindicated. Can be taken without regard to food. First dose phenomena on all ACEs and ARBs and orthostatic hypotension. Okay, calcium channel blockers. I skipped over in your text the direct renin inhibitor, Aliskiren. I know it as Tecturna. I very, very rarely have I seen that used. For mild moderate hypertension, used only with another antihypertensive medicine, has an additive effect with thiazide or ARBs. This drug, when used in monotherapy, has not proven to be effective in the African American population. It's not a very common drug, so I've just kind of skipped over it. Notice valsartan or your ARBs, chart 44.3, lots of drug interactions, so kind of look over that. Now your calcium channel blockers, we touched on those in a previous section when we talked about the heart rate. So I think I had this picture, and it also decreases contractility and decreases conductivity of the heart, so it helps with your heart rhythms, decreased demand, so that leads to a decreased blood pressure and bradycardia. It can cause some blocks. It definitely causes peripheral edema, especially in higher doses because of the dilation and relaxation. These two are highly protein bound, which seems to be all your antihypertensives, highly protein bound. Table 44.4 has a list. Dihydrophines are common, then lodipine, felodipine, all ending in the pine ending. The only ones to try to understand, the other different ones, diltiazem. Slow release is better. It's for angina pectoris, IV for cardiac dysrhythmia, so can be used for blood pressure, but not as often. It's not the best drug for just blood pressure. You have your verapamil for hypertensive in the slow release form. Can also be used for arrhythmias and angina. This notice here, abdominal discomfort, constipation. So here I thought was good your short-acting nifedipine, diltiazem, verapamil, and these long-acting amlodipine, felodipine. So other than nifedipine, the rest of the pines are all long-acting, which they usually are just given once-a-day dosing, other than nifedipine. Nifedipine, also known as Procardia, is not used as often. They do have an extended release one because the short-acting can increase your cardiac death, which I mentioned before. So diltiazem, verapamil, although the calcium channel blockers, the short-acting, they're used more for arrhythmias, if you remember from previous chapter. And then here's some more contraindications for calcium channel blockers. And I liked this. Again, very nice drugs to remember your calcium channel blockers. VND for verapamil, nifedipine, diltiazem. And then here's a list of some side effects. So I thought that was another good mnemonic to help you remember them. Hopefully this lecture was not too bad. I'm going to continue on chapter 45, so there's 2 more chapters in this section.